Based on what many of you might have seen in the most recent issue of JAMA, this topic about blood pressure treatment after thrombectomy bubbled up onto the top of the relevant list, and I thought it might be a good moment to review some of the trials that are out there and have a discussion about what we should do or not do differently. So let's see, can I make this work? There we go. So that's a picture of the first page of the editorial from the recent JAMA issue, and in it and in some of the other places, the background to this topic is summarized here. So, could better blood pressure control reduce hemorrhagic transformation? That's one of the key drivers of the search for a lower blood pressure target, is because we want to reduce hemorrhagic transformation, which of course is associated with poor outcomes. But alternatively, we might worry because autoregulatory dysfunction leads to a passive blood pressure dependency in blood flow in the brain, and marginally perfused areas, if we have more aggressive blood pressure targets, could be led to further ischemia, and that can lead to infarct expansion. So it's sort of these dual questions and competing priorities that we're trying to balance. American Stroke Association and European Stroke Organization guidelines currently, for many years really, since we started doing thrombectomies, have just recommended an identical to post IV thrombolysis blood pressure target of less than 180 over 105. So now 4 randomized trials have been reported, including 2 in this last week, and I've listed these 4 here in this table. I'll take a minute to sort of describe the overall characteristics of the studies. The BP target trial was the first one published in 2021, 324 patients at 4 French academic centers. They included patients who had endovascular thrombectomy, had gotten TICI 2B or 3 reperfusion, had a systolic of greater than 130 after the procedure. And here I'll use the laser pointer, and a pre-stroke MRS of less than or equal to 2. In this first trial, the randomization groups were a systolic target of 100 to 129 versus 130 to 185. They were trying to get there within 1 hour after the procedure was completed or after randomized, and then continued through 24 hours. The primary outcome was kind of not a phase 3 clinical trial. The primary outcome here was CT, any sort of intraparenchymal hemorrhage at 24 to 36 hours post intervention. The second study that came out was Enchanted 2/mechanical thrombectomy, or MT, in 2022. This included 821 patients at 44 stroke centers in China. Very similar criteria, TICI 2B or 3, but a systolic had to be greater than 140, not 130. Similar pre-existing lack of disability. And here the target, well, they had a slightly more disparate targets. The one target was less than 120 systolic versus a more standard 140 to 180. Again, trying to get it to the target quickly and pursuing that target through 72 hours. Their primary outcome was an ordinal evaluation of the modified Rankin scale. So that kind of includes the whole range of scores looking for changes. The third trial, which is one of the 2 that just came out, was the Optimal BP trial, just last week published. 306 patients randomized from 19 stroke centers in South Korea. Similar again, TICI 2B or better, systolic pre-stroke pre-randomization, greater than 140, and no significant disability. Here, the targets for blood pressure were less than 140 versus 140 to 180, again, starting early, and they went through 24 hours. And their main outcome was a dichotomized modified Rankin of 0 to 2. And then finally, the best 2 study, which was different. It was a Bayesian futility analysis trial, really a phase 2, potentially morphing to phase 3, depending on the results. Trial only included 120 patients at 3 American comprehensive stroke centers. But similarly, TE2B or better, reperfusion, systolic greater than 140, prior to randomization, and no significant pre-existing disability. They actually had 3 blood pressure targets: a less than 140, a less than 160, and a less than 180 within an hour. To get to their target was their goal, and to go for 24 hours at that target. They had 2 primary outcomes, which included infarct volume at 36 hours and utility weighted modified Rankin scale, which is an attempt to make the modified Rankin scale behave a little bit more like a normally distributed continuous variable. They did, it was kind of fancy statistically, the best 2 study. They also used linear regression to look for the slope of the changes in these outcomes based on these different blood pressure targets. And so, yeah, so that's the description, the overview of the targets. Any questions so far?
David,
Okay.
when they had the range, like the 140 to 180,
Yeah.
did they give people pressors if they were too low?
Yeah, that first bullet below the table, I did comment, I forgot to mention that in general, the blood pressure in the standard of care groups, which is, the higher blood pressure target groups, was not artificially increased with pressors. I don't think in any of the trials,
Okay.
if it was lower than the target,
Okay. Yeah.
as long as they weren't hypotensive. I think if they were
Right.
hypotensive, they might do fluids and things like that.
Yeah, it's pretty clear in the best 2 that they're just saying you got less than 180. So if you were down to 120 naturally, that was fine.
Yeah.
Okay.
Yeah. And but because of that, some of the differences don't really mirror the differences in the target groups, as
Right.
you'll see. So these were just a little bit of a comparison of some of the baseline characteristics in the 4 trials. The BP target trial had the oldest patient, 77, Enchanted 268, optimal BP 73, best 270. So, all older patients, but not our many patients in their 80s and 90s. NIH stroke scale scores were generally high, anywhere from 13 to 18. You had to have a large vessel occlusion. Optimal BP, they were a little lower. They might have had some more distal occlusions that they led into their study. The percentage that got IV thrombolysis varied from 30 to 50% or so, but certainly substantial groups got it. TICI 2B or 3, 2B versus 3 reperfusion. In 2 of the 3 that reported this, it seemed like it was about 50-50. In the Enchanted 2 MT trial, they claimed that 83% of their patients got TICI 3 reperfusion, which is pretty impressive. And then a couple of the trials reported time and target blood pressure. For BP target, it was about 2/3 of the time. For optimal BP, they said that it was 83% in the intensive group and only 42% in the standard of care group. And I think that reflects that, as Will was sort of mentioning, a number of people in the standard of care group end up having lower blood pressures naturally. And then 3 of the 4 trials reported hypotension, defined variously. The BP target, it was SBP less than 80, and it was greater, but still low numbers in the intensive versus the standard group. And then in these other trials where SBP less than 100 was considered hypotensive, 46% and 30% versus 12 and 17. So clearly, the more intensive targets is leading to more episodes of hypotension as well. And of course, we'd hypothesize that maybe that might be affecting the outcomes also. And because the first trial used any sort of intracranial bleeding on a 24 to 36 hour CT as their primary outcome, I just wanted to remind everybody about the Heidelberg bleeding classification system, hemorrhagic infarction 1 and 2, and then parenchymal hematoma 1 and 2. Those are in order of progressive worsening. And you can see here are some examples. This is a HI1, so just a little bit of petechiae in the bed of the infarct. HI2, a little bit more confluent petechial hemorrhage, but no mass effect. PH1, there's clearly a hematoma itself within the infarcted tissue, but it occupies less than 30%, and there's no big-time mass effect. And then PH2 is hematoma, at least 30% of the infarcted tissue, and with obvious mass effect. So in the BP target trial, again, the targets were 100 to 129 versus 130 to 185. The average blood pressures were only different by 10 points, 128 versus 138. And as I mentioned, any bleeding on that CT was their primary outcome. It was open label, and they powered it for 15% absolute reduction. Their hypotension definition was less than 80. And these are the main outcomes. In their modified intention to treat trial, there's really no difference in the odds of finding any of this bleeding on CT scan. And then they had a bunch of secondary outcomes, favorable MRS of 0 to 2, no significant difference, excellent outcome, no significant difference, change in the NIHSS, no significant difference, and then a number of safety episodes, all no significant differences, although, as I mentioned, the hypotensive events were greater. So BP target really was quite neutral, and the more aggressive target did not diminish the possibility of these varieties of bleeding. I didn't see where they broke down the actual bleeding subtypes, and that might be interesting. Although actually here's the PH2, now that I mention it, at 24 to 36 hours. And again, there was no significant difference. If anything, it was higher numerically in the intensive group, and the same thing for symptomatic ICH. So really no benefit on reducing hemorrhage, which is what they were really trying to prove.
And David, in that they must have been using MR. I mean, they're having 40%.
Oh.
Well, just look at the primary outcome. They have 40% getting a hemorrhagic infarct. That seems high.
It's very clearly described as being on the CT scan. So I agree, that seems like a very high number.
Yeah, wow. Okay.
But maybe a lot of it was, PH1, because here the PH2, well, real hematomas were only 9% overall. So a lot of it must be smaller types of bleedings.
Okay.
And then the Enchanted 2 study, this was less than 120 versus 140 to 180. So these might have been the biggest differences in blood pressures. The average at 24 hours was 121 versus 139. This one was stopped early because there was a clear difference between the groups, and when they unblinded, it turned out it was worse outcomes for the intensive group. Here's the ordinal MRS calculation with the odds ratio of 1.37 for worse outcomes was statistically significant. And you can see that the more intensive group, sort of has less of the left hand parts of the bar and a little bit more on the right side compared to the standard of care more intensive group. Other secondary outcomes were also worse: early neurodeterioration, death and disability, major disability, health-related quality of life, and there was no change in mortality overall, and again, no reduction in parenchymal hemorrhage as they measured it. It wasn't quite the same measure, but still no difference in hemorrhages. Then coming to the more recent studies, the optimal BP trial, less than 140 versus 140 to 180. The differences here were about 10 millimeters of mercury, 129 versus 138. This one was also stopped early because of worse outcomes in the intensive group. You can see here the adjusted odds ratio, and this was, I think, a modified Rankin 0, 1, or 2, was 0.56. So you were likely to have that good outcome significantly less likely in the intensive management group, again, showing that these left parts of the horizontal bar are smaller compared to then in the conventional management group. Other secondary outcomes were also worse, including the modified Rankin shift, some quality of life measures, and actually malignant edema, which I can't totally understand, was more in the intensive blood pressure management group. And finally, again, no change in mortality or hemorrhagic conversions of any variety. And then finally, the best two study. This is the one with the 3 blood pressure goals: less than 140, less than 160, less than 180. And the difference blood pressures that were achieved in those groups. And again, there was only 40 patients in each group, but the different blood pressures were 122 versus 130 versus 129. So there's really no blood pressure difference between the 160 and the 180 groups. They set these futility thresholds for their final infarct volume and utility weighted. I like that it becomes UW MRS. And their utility weighted MRS, they didn't quite reach their futility thresholds, but everything was sort of in that direction. Again, there was no change in mortality or rate of intraparenchymal hemorrhage. But then they did this other analysis where they were looking at the predicted probability of success for a larger superiority trial, given the data that they had in this smaller futility trial. And if you look at the comparison between the 140 and the 180 group, using the utility weighted modified Rankin, the chances of finding a significant difference were 16%, 21%, and 25% if you use sample sizes of 400, 800, or 1,500 patients. And they had sort of predefined that if they couldn't get it to 25% or more, it probably wouldn't be worth pursuing. So they were really right at their own threshold here. And if you compare the 160 to 180, the probability of finding benefit to lowering was even further reduced, really didn't meet any sort of threshold. So they concluded that there would be a very low probability of benefit in any future trial based on a similar design. And so I think to some degree, this type of trial looking to lower the blood pressure further may be dead in the water for the moment. These were the cool outcome graphics from the best 2 trial. Here's just the infarct volumes at 36 hours in the less than 140 group, less than 160, and less than or equal to 180. There were no significant differences, as we've mentioned. And then if you compare the less than 140 or the less than 160, both compared to the same less than 180 group, you can see that in general, the less than 180 group had more stuff towards the left side of the bars. You know, if these lines, which are connecting different parts of the bars, if they're slanted that way with the top being to the left and the bottom being down a little bit more to the right, that suggests that the bottom bar did better. And it looks that way, at least numerically, in both comparisons here. So this is the blood pressure recommendation from the American Stroke Association from 4 years ago. Blood pressure should be less than 180 over 105. The class of recommendation was 2A, and there was the one study, I think, that no, I'm sorry, there were no randomized trials. So it was sort of a lower level of evidence for this. They may be able to upgrade the level of evidence for both of these. And here's one for successful reperfusion. This is for sort of everybody, and this is the successful reperfusion. They say you might go even lower, but there's not a lot to support that. The level of evidence may go up for these, but I don't know that the recommendations will be changing at all. And so there are remaining questions. I think clearly there's a great variety of personalized cerebrovascular physiology that's going on post all of these strokes. Probably a lot of variability from person to person in large groups. There's no benefit. Most of these trials also did subgroup analyses by age or severity or TICI-2B score or whether they got thrombolysis, and they really weren't able to identify any subgroup that seemed to benefit. Nonetheless, subgroup hypotheses are a favorite pastime of clinical researchers. And so in some of these articles and editorials, they wonder about if we could identify patients at high risk of hemorrhagic transformation. Maybe they would be the ones that would benefit from the lower blood pressure, or if there was high risk of hypotension or loss of penumbra, loss of penumbra, maybe those patients with a bigger, still vulnerable penumbra would benefit more from less aggressive blood pressure control. Could we use TCDs to individually assess their autoregulation and thus tailor our blood pressure targets? All unanswered questions. People also discussed the frequency of monitoring. A number of these trials, I think actually most of these trials, did not use arterial lines. They used non-invasive frequent measures. And then blood pressure variability, which we know in many circumstances has been associated with poor outcomes if there's higher variability, is another interesting factor to consider. And so just concluding, having reviewed these studies, now multiple trials of intensive blood pressure control have failed to show a benefit, and some have shown harm. None have shown a decrease in bleeding complications, which is really, I think, the main driver for investigating this question. Many patients don't even need meds to achieve the less than 180 goals. And average BPs in the less than 180 group, I feel like I didn't finish that sentence there, were often quite a bit less than 180. And so for the moment, and possibly even for the long term, the systolic goal should remain less than 180, not a more aggressive target. And I think because there was some evidence in some of these trials that hypotension worsened outcomes, it should be carefully avoided, as we try to do. But with sedating medications and many of these patients intubated, sometimes we don't do so well avoiding hypotension. And I can't emphasize enough how important it is for us to be paying careful attention in the ICU in those first 24 hours post-intervention, where sometimes if we take our eye off the ball for just a minute, suddenly somebody's systolic can be less than 100 pretty quickly. So that's all I got. Interested to hear what people are thinking about all of this as well.